Hi everyone and welcome to our new series Croí Connects. We've lots of questions coming in from our Croí community and we're connecting with medical experts to get your questions answered. Over the coming weeks we're going to cover a series of topics including heart disease, stroke, healthy lifestyle, diabetes, obesity and of course COVID-19. This week we're delighted to speak with Bill McEvoy, Professor of Preventive Cardiology at NUI Galway, who's also Consultant Cardiologist at Galway University Hospital and Medical and Research Director of the National Institute for Prevention and Cardiovascular Health, which resides here at the Croí Heart and Stroke Centre. Thank you for joining us, Bill.
Thank you, Irene. It's a pleasure to be here.
Okay, so to begin with, lots of people have been asking, what's the difference between a preventive cardiologist and a general cardiologist?
Well, I think that's important to know about. A preventive cardiologist is somebody who's done additional training in the control of blood pressure and cholesterol, as well as other cardiovascular risk factors. Blood pressure is commonly managed by general practitioners, as is cholesterol, but there are cases where it can be very complicated to manage these patients. Sometimes for genetic reasons, but sometimes for other reasons. And there is a complexity to the management of blood pressure, particularly secondary hypertension, form of high blood pressure. And also some complexity to manage of familial lipidemias or hereditary high cholesterol, which is a genetic disease. And there's some complexities to both of those which require additional training. In many ways, it's also a mindset. Cardiologists historically focused a lot on advanced stage of disease, so opening blockages, fixing broken hearts, fixing valves that are deteriorating. A preventive cardiologist has a different mindset where they're focused on lifestyle and factors and drivers of disease to try and to get involved to prevent disease from becoming advanced. In America, it's been a long-standing subspecialty cardiology, just like any other subspecialty, including interventional cardiology, heart failure, electrophysiology, which is pacemaker and heart rhythm disorders, and congenital heart disease. And so it's been a long-established, especially in the States, which is where I trained. But there's also been, I think, a good track record in Ireland even of preventive cardiologists going all the way back to Richard Mulcahy, Ian Graham, Owen O'Brien. Ireland has always had a focus on prevention that I think has preceded the interest in America. And so I'm hopeful that I'm kind of part of a new wave of cardiologists in Ireland, non-invasive cardiologists. Those are cardiologists that don't do cath lab procedures. I do general cardiology as well as preventive cardiology, I would say. So I round on patients in the hospital. I do consults. I have a general cardiology clinic. I look at images, echocardiograms, CAT scans of the heart, etc. But my subspecialty interest and my additional training was in preventive cardiology. I also have to train in epidemiology, which is public health and biostatistics, which lends itself well to the area of preventive cardiology.
Excellent, excellent. Bill, we've been hearing a lot about people with underlying cardiovascular conditions being at higher risk of complications if they contract COVID-19. Why is that?
I think there's probably a number of reasons. It's a new disease. We're still learning a lot about COVID-19. The thing that's well established at this point is that patients who are older tend to have more severe consequences of the infection. What tracks with age generally is other chronic diseases, including cardiovascular disease. And so some of this association between cardiovascular disease and poor outcomes in COVID-19 might be explained by age alone, because those who are older tend to be more likely to have cardiovascular disease. And also we know those who are older do worse when they get the infection. There may be more to it than just that. There are a number of studies now that have suggested patients with high blood pressure appear to be at higher risk for developing severe complications of COVID. And that can also be explained in some part by age, but the signal is very strong in a number of studies from China and from Italy, and it's raised the question as to whether something about high blood pressure, which may independently affect the outcome of COVID-19. So it's ongoing blood pressure medicine infection. That's actually something that we ourselves are interested in here in Galway, in that we are doing a study, and it's a trial called the Cocooning trial, where we're looking at patients who are on certain types of blood pressure medicines, in this case specifically ACE inhibitors and angiotensin receptor blockers. That would be your lisinopril, your perindopril, your ramipril, your valsartan, your losartan, those medicines. And we are testing whether or not continuing those medicines versus switching to an alternative blood pressure medicine either increases or decreases the risk of getting COVID. And we're very excited about that study. It's very important because of our cardiovascular disease patients. So many adults in general have high blood pressure and are being treated. And if blood pressure medicines impact in any way on COVID-19, we need to know about that so we can ensure that patients are on the safest regimen.
Bill, that was one of the questions that came in, where people are concerned about whether some blood pressure medication can make COVID-19 worse. And we're wondering, should they stop their medication?
I missed a little bit at the start of that question, Irene. I apologize. It may be a bad connection. Could you repeat that?
Yeah. So, Bill, one of the questions that came in was people are wondering, because they'd heard a little bit about blood pressure and particular medication, whether it can make COVID worse if they contract the virus. And they were wondering, should they stop their medication?
Absolutely not, Irene. I think that at the moment, the concerns around blood pressure medicines and COVID-19 are quite speculative, and we don't know. And I will put it to you like this. There have been some who have suggested that certain blood pressure medicines might increase the risk of COVID-19. There are reasons for that. Those reasons are very speculative. They're based on studies from animals. And so it's hard to say for sure that that's the case in humans. But on the other hand, there are those who feel that the same type of blood medicines might actually improve the course of patients with COVID by reducing the likelihood of developing lung disease. So on one hand, you've got people saying that certain medicines might be bad. On the other hand, you've got others saying that the same medicines might be good. All that is that we don't know. Obviously, what we do know is that blood pressure is a significant risk factor for heart disease and stroke. We do know if patients stop taking their medicines, their blood pressure will generally start to creep back up and become poorly controlled again. And we do know that patients that are not taking their medicines are more likely to have heart attacks and strokes. And so I think what we know should supersede what we don't know and what's speculation. And at the moment, what we do know is those who need to take these blood pressure medicines should continue to take them. Guidelines or societies on both sides of the Atlantic, the European Society of Cardiology, the American Heart Association, American College of Cardiology, have all said very strongly that patients should continue taking the blood pressure they are prescribed. We are doing more research into this, but right now it's really in the research realm. It's not something that should impact on how you're treating yourself.
So we need to stick with the facts really and the evidence from the reputable sources. One of our Back to Fitness participants asked us a question. They have high blood pressure and they're under 70. Their blood pressure is very well controlled. Should they be cocooning?
I don't think so. I think that by virtue of their age, they're likely to be lower risk, less than 70. And having blood pressure that's well controlled is probably not more of a risk state for developing COVID or having a bad outcome from COVID than a normal individual. So if you do 60-year-olds, one of them has high blood pressure, but it's well controlled on treatment. The other 60-year-old has never had high blood pressure. Probably both of them have a similar risk from COVID. So as long as the blood pressure is well controlled and that patient's still taking their medicines, they're likely to be no different risk than anybody else their age. And we generally don't recommend cocooning for people under the age of 70. Now, obviously, it's an individual choice. And so it makes sense that if somebody's very worried and they have the capacity to self-isolate, maybe to the extent that you would call it cocooning, and that's their choice, then there's no reason why they can't. But also, there's no dictate that they should be cocooning either.
Okay. So our next question comes from Mary and Claire, and she's wondering, she was discharged from hospital. She had a heart bypass 3 weeks ago, and she was wondering, what should she be doing? Can she exercise? And again, she was wondering about cocooning. Now, she didn't mention her age, Bill.
Okay, well, I think in Mary's case, having just gone through a fairly major operation, she's probably going to be convalescing, recuperating from that. While she's gaining her strength back, getting back on her feet, she may be at higher risk from having a bad outcome if she was to get COVID-19. I don't think she's necessarily at higher risk for contracting the disease in the first place, but if she were to get the disease for whatever reason, she might have a harder time with it because she's just been through a big operation, which involves operating on the chest, and the lungs themselves can take some time to heal up, and we know that COVID-19 affects the lungs. So I think Mary would be best served by self-isolating as much as she could for short term while she's recovering from her operation. Obviously, if Mary is a 40-year-old, which is unlikely if she's had bypass surgery, but it's not impossible, we could be maybe a bit more relaxed about that. But assuming that Mary's in her 60s or more, which is the average age for heart bypass surgery, and given how significant that surgery is and how much of a stressor it is on the lungs and the chest, and because we know COVID really affects the lungs and the chest, I would recommend that Mary do keep quite isolated so that she reduces her risk of developing the infection. It's important to stress, though, that she can exercise at home. She just needs to be careful not to do too much exercise with her upper extremities, too much arm exercises that can kind of cause the chest to pull apart. So I wouldn't be doing press-ups and pull-ups, things like that. But if she's doing steps or walking around the house, even if she has a treadmill or a stationary bike in the house, those things would be fantastic and should be encouraged. One of the issues that we have at the moment, which is something that is a concern of mine, is that because of COVID-19, our cardiac rehab centers the hospital-based rehab centers are closed. And so Mary would have been a candidate for cardiac rehab, whereas now we can't offer that for the short term. So it is important that Mary gets some exercise at home, as long as she's not doing too much with her arms and her chest.
Yeah, I think that's very good advice, Bill. And of course, keeping an eye out on her wound as well, and linking in with her GP if she has any concerns as well. Okay. Absolutely. So Stephen wrote to us. He's a past Croí night run participant. He's 31. He had a procedure last year to correct a heart rhythm problem, and he's wondering, is he high risk?
No.
Great.
No, he's good.
Excellent. I think, some of the queries that we're getting in have been from people who have various different heart rhythm issues. And, often people are concerned that will the virus affect any implantable devices like ICDs or pacemakers? Do we have any evidence around that, Bill?
We don't have clear, strong evidence from COVID-19 that I know of, but we do know that viruses don't infect pacemakers in general. And so I would be very surprised if COVID-19 is any different in that regards. So for me, because we know that viruses do not infect pacemakers, I'm very confident in assuming that COVID-19 will also not infect pacemakers. So that's not a concern that I would have, and I would reassure patients who have pacemakers or other implantable cardiac devices that that is not a problem in terms of getting that device infected from COVID. In terms of heart rhythm abnormalities, there may be some rare instances where COVID-19 can affect the heart, and that may induce heart rhythm abnormalities that are spontaneous related to the infection. It's not been shown that people who have a history of heart rhythm disease are at any different risk or any higher risk than others for developing the disease or for having a worse outcome. So in general, I would probably consider them to be lower risk than somebody who has, for example, heart failure, which is a pump problem where the heart's not pumping well, and that can oftentimes lead to shortness of breath. The fluid can back up behind the heart in the lungs. Those patients are at higher risk because we know that COVID-19 has a propensity for the lungs and can really hurt the lungs. And so any underlying condition that affects lung function is probably going to be higher risk. So again, heart failure would have consequences for lung function, whereas heart rhythm disorders generally don't. So besides age, if you're young and you have a heart rhythm disorder, I think you're probably not at that high a risk over and above the average individual walking around in our community.
Great, that's great reassurance, Bill. This was a call from John in Connemara. He's wondering, he had 3 stents inserted 2 months ago, and he's due to be called back to outpatients shortly. He's wondering, will this appointment go ahead?
Yes, we are, at least in Galway, University Hospital Galway, we are running our outpatient departments as normal. And so our outpatients in Galway continue. However, they are not in person. And so patients are not coming in to the hospital for their outpatient visit. We are calling them. So he will get a phone call on the day of his appointment from the cardiology team, and we will ask him how he's doing and address any concerns he has. We are in a position to obviously make changes to medicines if necessary. It's hard to do a full clinic visit over the phone in some respects because you're not examining the patient and such, but he will have a phone appointment if he's scheduled here in Galway.
Excellent, excellent. If you're scheduled for a Tabi, should you cancel or go ahead in the current COVID-19 environment? Obviously, this is from somebody who has been diagnosed with heart valve disease.
I think that's an individual decision between the patient and the doctor who's planning the Tabi. In general, I would say probably no particularly strong reason to cancel, although if the patient is very stable and this is a Tabi that could be deferred until the COVID-19 crisis has passed, that would be a reasonable thing to do just to avoid developing the infection in the hospital. Many of these Tabi patients are at the point where they need to have something done sooner rather than later. And so there's going to be some Tabi patients that are waiting for Tabi who really ought to be done as soon as their scheduled appointment. I think what's important to emphasize again is that it'll be an individual decision, and the team who are arranging the Tabi will communicate with the patients about whether or not they are going to bring them in for Tabi now, which is usually in the case of somebody who needs to have it done sooner rather than later, or whether or not they perhaps may defer it to later on if somebody's otherwise very stable.
And briefly, Bill, for listeners who are joining us today, would you mind explaining what is a Tabi?
Yes, it's a procedure whereby we can replace a heart valve, typically an aortic heart valve, and we do it through a puncture in the artery in the leg. We call that percutaneous, so through the skin. And we're able to go up from the artery in the leg into the heart with a long tube called a catheter. And on that catheter, we have the new heart valve, which we can inflate on a balloon that deploys the valve, or that puts the valve in the place of the old valve and replaces the old valve, the diseased valve. So you're left with a new functioning heart valve. It's a prosthetic valve, so it's man-made, but it's a new functioning heart valve. and it's done through a small incision in the leg, which
Wow.
is a very different approach than our traditional way of taking care of these patients, which would have been open heart surgery. Open heart surgery is still recommended for certain type of valve problems, and certainly for patients who are young and who will need the valve for many, many years. We're still performing open heart surgery, the traditional heart valve replacement surgery. But for older patients, and particularly those with aortic valve disease, especially when it's termed stenosis, when the valve is not opening well, it's stiff, we are doing more and more of these Tabi procedures because they're less invasive and patients get back on their feet more quickly and get home more quickly, and generally do better actually with these Tabi procedures.
Excellent, excellent. Does having a replaced valve put you in the higher risk category again, is another question?
Kind of similar to my response with
Yeah.
pacemakers and with heart rhythm disorders. I'm not sure it necessarily puts you at a higher risk on its own. Obviously, people who have had replaced valves tend to be older because valve disease tends to be a problem of older adults. And so it's true that most individuals who've had a replaced valve are at higher risk, but that would probably be mostly because of their age rather than the valve itself. And so again, if they took a friend of theirs who was the same age of theirs who hadn't had a valve replacement in the past, they may be at similar risk to that friend. So it's really about the age more than the valve itself. Obviously, like Mary from Clare, if they've just had a big heart surgery, i.e. if the valve is just replaced in the last few weeks, then that's a different kettle of fish, because that's a scenario where, like Mary, the chest and the lungs are still recovering from the surgery. And so they probably would be at higher risk from having a bad outcome if they were to get COVID, because COVID infects the lungs quite severely. And those patients would probably be best to self-isolate. But again, individuals who've had a valve many years ago who are kind of otherwise well, besides their age, I'm not sure that there's much extra risk there.
Great. Thank you, Bill. We've been hearing a lot about wearing masks and should people be wearing, should they not, and so on. One of our volunteers from Mayo called us and was wondering, should people with heart conditions be wearing masks at the moment?
It's a very good question. It's a difficult one to answer with full confidence. I think there's two camps that have emerged when you look at the news and read medical literature, and those two camps, of course, being those who are pro-masks in public versus those who say that masks need to be preserved for when they're needed, most needed, which is generally in healthcare settings. I think from my own perspective, I'm kind of a prudent person, and I don't see a big problem with masks in the community, because I do agree that the idea that if we're all wearing masks, then I protect you and you protect me. We've all heard that sentiment, and I think there's an element of truth to that. So it's important to emphasize that the mask may protect others if you are infected, and if everybody's wearing a mask, then you're protected from them. So it's a communal thing. But wearing a mask isn't going to, an individual going out there wearing a mask isn't going to protect that individual, because the virus can still get onto the outside of the mask if other people are shedding the virus, and the virus touches off the front of the mask, so to speak. It's there on the mask, and if you handle it, then you might infect yourself later on, you know, if you touch your face, etc. So I think it's just important to realize that if you wear a mask, you're not really protecting yourself per se, you're protecting others. But it's true that if everybody does it, then we are starting to protect each other, you know. Unfortunately, I don't think we have the supplies to have everybody wear masks. But there are some individuals who are making efforts to make home-made masks, and those would be cotton-based masks. I think, again, they have maybe some effect. It's a very difficult area to know what's right and what's wrong. And if you look at the guidance from For example, America, the CDC have recommended that people wear masks outside. Obviously, we know in China people do it. We know in South Korea people do it. And in those areas, they've got a handle on the infection quicker. But as far as I'm aware, the European directive, and certainly the Irish directive, is that we do not all need to wear masks. So again, it reflects the uncertainty, reflects the polarized opinion about this. And I don't think I have the right or wrong answer or golden bullet. I just think that it makes sense to me that if we could all wear a mask when we're outside, it might protect others.
Great, great. Bill, thank you very much for your time today and for answering all of the questions and queries that we've received. I think it offers a lot of reassurance to members of the public and people living with heart disease that the cardiology departments and outpatient services are still very active and are open for business per se. And I think, you know, certainly you've offered really good reassurance regarding some of those specific concerns because, you know, it is a worrying time for people and, you know, it is important, and that's the purpose of the Connect series, is that we bring, you know, experts and answer the key questions that individuals in the community have, and that, you know, we share this important information and the factual information as well. Now, with this series, we always at the end conclude with asking our guest speaker, our guest expert, for, you know, what their key take-home messages are, or any information that you'd like to emphasize today, Bill, from a cardiology perspective.
Well, thank you, Irene. It's a pleasure talking to you, and it's great to get some information out to those who need it. I think for me, one of the things that's become more and more apparent as we go through this COVID-19 crisis is that it's important to stress to everybody out there, the public at large, that cardiovascular disease remains a significant problem in our communities. It remains a dangerous condition to have and to have untreated. And if you're having any symptoms suggestive of a heart problem or cardiovascular problem, chest pain, shortness of breath, and the like, it's not a good idea to sit on that and to wait. I understand that the public can be told to stay at home as best they can, but heart disease is a situation where we would advise patients to be sure that if they're having symptoms that they would otherwise normally come in to be assessed for, either to their GP or to the A&E, that they go ahead and do that. Do not sit on heart disease. We're seeing a fair amount of patients presenting later with heart attacks than they would normally. And obviously the concern is that they wanted to wait it out to see if it would pass and didn't want to come into the hospital because of COVID-19. I would stress that that's not the right way to go about things. If you have problems that warrant an A&E visit, come to the A&E, don't sit on it, don't leave it too late. We have set up systems in the hospital whereby we stream patients into two distinct groups. One is the COVID possible and positive group, another is a COVID negative group. And so we triage, or we ascertain immediately when patients come to the A&E if they have COVID or no COVID related issue. And those who don't have a COVID related issue go into a separate group. So you're not, your likelihood of developing COVID in the hospital is minimized. Can't say it's zero, but it's not zero when you walk around the community either. And so I just wanted to emphasize to patients, do not fear the hospital. We have set up systems whereby we can keep them safe. We can minimize the risk of getting COVID. And we know that some patients have been waiting on their heart problems for too long, and that's going to cause more trouble down the road. And sometimes it can be a bit too late. So the hospitals are open, like you said. In fact, in some respects, some of our health system is quieter than average because we're seeing less patients come through. And so if in many ways, this is almost the time to come in, particularly if you have symptoms that are concerning. So don't wait on those symptoms.
Excellent, excellent message, Bill, to conclude on. And can I thank you on behalf of Croí and colleagues here, you know, for all of your efforts, and you know, to congratulate you and your colleagues in terms of all of the work that you're doing on the front line. These are very difficult times, and it really is appreciated. So Bill, thank you very much. And again, just to re-emphasise to members of the public that over the last number of weeks, the health team here in Croí have been developing lots of resources for individuals affected by heart disease. So even for Mary and Claire, who was asking the question about what she should be doing now, we have some very nice exercise videos online that people can follow that have been developed by our physiotherapist. Really nice messages in relation to practical tips and advice relating to healthy eating and looking after your emotional health and well-being at this moment as well. So please do visit our website, croí.ie. Next week, we'll be returning with another session, and we're delighted to have Suzanne Seary, who's a dietitian who works closely with Croí. She's also a clinical tutor in nutrition and dietetics at University of Limerick. So please do now get your diet and food-related queries to us so that we can present to Suzanne next week. And of course, certainly with the Easter weekend looming, I'm sure there'll be lots of queries after the weekend. And also, please bear in mind that we have our dedicated telephone helpline that's open from Monday to Friday on 091 544 3100, and our health team are ready to take your questions and queries. And thank you for joining us today. Take care, look after yourself.